All right, we're going to go ahead and get started for our seminar today. Welcome, everyone. We are right on to our last out of the 4 seminars that we have in the fall Global Health Seminar Series. And today we are really honored to have Dr. Toby Sapiano, who is a global health professional with over 23 years of experience in the development, implementation, administration, and evaluation of domestic and global HIV policy programs. Dr. Sapiano has been with the U.S. Centers for Disease Control and Prevention since 2007, where she has held multiple positions in the National Center for HIV, viral hepatitis, and STDs and TB prevention, and the Global Health Center. She has also served as the Senior Technical Advisor for the HIV prevention in the CDC South Africa office, and as the Associate Director for Management and Operations in the CDC office, Uganda. So additionally, Dr. Sapiano has also contributed to multiple CDC emergency responses, including Ebola, Zika, and in 2019 HIV outbreak response in Cabell County, West Virginia. So we are really honored to have you, Dr. Sapiano, and the floor is yours. We are really excited to have you speak to us on this important topic.
Great. Thanks, Dr. Secunde. I have to say, I don't know if it's okay to call, I'm going to assume it's okay to be called doctor at this point. I will graduate on the 15th of December. So if I've successfully defended, then I'm going to go ahead and consider that it's okay to refer to myself as doctor. So I appreciate that. I am going to go ahead and share my slides. This always takes me a second. Are you seeing my screen with the like the note slides?
No, the notes are not there. It's just the screen.
Okay.
Yes.
Are you seeing my screen at all?
Yes. Looks good.
You are. Oh, okay. So so now I can just slideshow. Now you're seeing my title page? Correct. Perfect. Okay. Good. All right. So as Dr. Secunde said, I am Toby Sapiano. You maybe had seen my bio. I won't rehash it all. I'm currently a public health advisor in the Special Initiatives Branch in DGHT in the Global Health Center at CDC. I've been with CDC since at the very end of 2007, early 2008. I've held multiple, both technical and management positions at CDC across a number of series. So if you're ever interested in seeking a federal position and are interested in working across different series at federal organizations, let me know, because I have experience as a health advisor, a behavioral scientist, and also a health scientist. And so I really started and while I've been at CDC, I have jumped from domestic HIV to global and then back again and back again. So not a lot of people go between the two programs, but it's becoming increasingly common for people to start doing that as we kind of move more into the space where our public health professionals are cross-trained in technical and management and operations kind of side of the house. And you can see on this slide, so I didn't want to have just my whole bio here. You can see some of the places that I've worked. And like many of my colleagues, I started my career in the Peace Corps. In 2000, I was a Peace Corps volunteer in Mali in West Africa. And that was the year I was there, the years I were there were the first years they were having the HIV volunteers. So I've actually worked in HIV for my entire career. So since 2000. And you can see there's some other things on here I've done. I have experience. We're going to talk a little bit about the multilateral partners. And so I have experience with those organizations, with the UN, with UN Women, and like Juliet Red. I've worked in the CDC South Africa and CDC Uganda offices, which are actually our largest PEPFAR offices. So I do a lot of presentations, so don't groan. But before we get started, I won't make anyone do an icebreaker. But before we get started, I do want to test everyone's knowledge with a few questions here. I did not create a poll, so just bear with me. We're gonna do it the old way. So I've got 4 questions. No Googling it, no looking it up. But I'd like to see what your responses are. So before I say that, for those of you who don't know, tomorrow is World AIDS Day, December 1st. It's a day where we reflect on the progress that we've made, and we think about the work still yet to be done on the global HIV response. And so my questions are all going to be related to HIV and some related to World AIDS Day. So the first report describing AIDS in the United States was a CDC Morbidity and Mortality Weekly Report published on which of these dates? December 1st, 1981. So just put your answer in the chat, and no one's going to be penalized for answering incorrectly. June 5th, 1981, January 1st, 1982, or August 5th, 1986. All right, I see the reply. So the correct answer is actually B, June 5th, 1981. And if I could move those little red bars, that's what we would see here. All right. All right, so the next question. The first World AIDS Day was observed on 1 December in which year? 1981, 2000, 1988, or 1995? A, B, C, or D? All right, so those of you who put C, you got it correct. It was 1988. Let's go to, we have 2 more, and then we'll get really deep in the weeds on some data. So let's enjoy these slides while you can. So which donor program contributes the most resources to HIV globally? The Global Fund to Fight AIDS, TB, and Malaria, the Bill and Melinda Gates Foundation, the UK Department for International Development, or DFID, or the US President's Emergency Plan for AIDS Relief? A, B, C, or D? All right, so a lot of you got this. I'm pleased to see that. So the largest global contributor to HIV, international HIV programs, is the US President's Emergency Plan for AIDS Relief, or PEPFAR. And we're going to talk a little bit more about PEPFAR in a minute. And I'm going to keep track of time because I'm often bad at that. So let's see. All right, final question. Which US presidential administration was responsible for launching PEPFAR? The Obama administration, the George W. Bush administration, Reagan administration, or Clinton administration? All right, so let's see. That's the one good thing about polls, is you can see how many people have finished. I'm trying to track here. All right, so for those of you who answered B, you are correct. Congratulations, pat yourself on the back. It was the George W. Bush administration. And again, we're going to talk a little bit about that. Okay, so today's presentation is going to cover I've recently defended my dissertation on October 16th. And so I really didn't adapt this presentation too much. So this presentation is going to mirror my dissertation presentation very closely, but hopefully we'll have a little time for a discussion at the end. So today I'm going to cover the background, methods, results, and conclusions sections of my dissertation. And so if there's time, I'd really like to have a group discussion on the implications of this research on PEPFAR sustainability efforts. And I'm actually going to stop sharing my screen just because I sometimes have some bandwidth issues. So I'm here though. All right, so into the background. Major global efforts over the past 20 years have resulted in significant progress towards ending the global HIV epidemic. Despite this progress, 1.5 million new HIV infections and 650,000 deaths from AIDS-related causes occurred in 2021. Currently, there are more than 38 million people living with HIV, and 82% of those individuals were living in low and middle low and middle income countries. And I'll often abbreviate that to LMIC if you hear that. So as you can see, HIV remains a significant threat to public health, health security, and development globally. As part of the Agenda for Sustainable Development adopted by the United Nations General Assembly in 2015, the international community has committed to ending the AIDS epidemic as a public health threat by 2030. To achieve this goal, UNAIDS established the Fast Track strategy to end AIDS, also known as the 95-95-95. According to this strategy, 95% of people living with HIV will need to know their status, 95% of people with HIV need to be on treatment, and 95% of people on treatment will need to have achieved viral load suppression. Data suggests that achieving these goals will reduce the number of new HIV infections below the total number of deaths from all causes among people with HIV, effectively ending the HIV epidemic. And you will see definitions of ending the epidemic vary from different sources, but we're going to stick with what I've just discussed and the 95-95-95 targets. So to lay the foundation for my research, we really need to take a step back and look at the HIV epidemic in the early 2000s. At that time, HIV was taking a devastating and disproportionate toll in low and middle income countries. Simultaneously, developments were taking place in the medical treatment of AIDS and the prevention of mother-to-child HIV transmission. The availability of these new medications presented a window of opportunity, enabling the Bush administration to launch the United States President's Emergency Plan for AIDS Relief, or PEPFAR, in 2003. PEPFAR was initially conceived and implemented as a 5-year bilateral or government-to-government $15 billion emergency humanitarian aid response to build the systems and infrastructure needed to quickly scale up HIV treatment services in 15 low and middle income countries. Now, at the time, the selected 15 countries were shouldering more than 50% of the global HIV burden. Since 2003, PEPFAR has been reauthorized 4 times and expanded in size and scope. Currently, the program provides HIV treatment and prevention services, as well as myriad associated support in more than 45 countries. And over the past 19 years, PEPFAR has actually become the largest bilateral global donor program focused on a single disease in history. The program has actually invested more than $100 billion responding to HIV in low and middle income countries, or LMIC. And also, just to point out, you may have heard about this, but PEPFAR is still waiting to be reauthorized for the 5th time. And so the program has actually not been reauthorized at this point, although through various mechanisms, it is currently in operation while the decisions are made in Congress to reauthorize. So you may have heard of that in the news. So over the years, in addition to strengthening global health systems and training hundreds of thousands of healthcare workers, PEPFAR has provided HIV treatment to more than 20 million people living with HIV. It has been responsible for more than 5.5 million babies being born HIV-free, administered more than 64 million HIV tests, and provided pre-exposure prophylaxis, or what's referred to as PrEP, to more than 1.5 million people. When you compare HIV treatment outcomes between PEPFAR countries, which you can see in these charts in blue, and non-PEPFAR countries in orange, you can see that low and middle income PEPFAR countries have achieved relative HIV treatment parity with non-PEPFAR high income countries. This suggests that LMIC with PEPFAR perform as well as high income countries when it comes to getting people on ART and supporting viral load suppression. The last 10 years have seen increasing gains made in PEPFAR-supported LMIC toward achieving epidemic control. During the same time, competing health priorities such as the rise in non-communicable diseases and the emergence of health security threats such as Ebola and, of course, COVID have shifted global health and donor priorities. In the face of a changing donor landscape, it is more important than ever that PEPFAR takes steps to transition national HIV programs wholly to partner country governments, but in a way that protects the US's $100 billion investment, as well as all of the gains made toward epidemic control. So this is a big ask. To address these shifts, PEPFAR released their latest 5-year strategy, which prioritizes sustaining collective gains made toward ending HIV while transitioning to a country-led response. So in PEPFAR, we'll often talk about this as sustainability, and soon we will be releasing sustainability roadmaps to assist countries in achieving sustainability. So this idea of sustainability has become increasingly important within PEPFAR. Prior to the release of the 5-year strategy that we're talking about here in 2022, PEPFAR sustainability efforts were really focused on the completion of this biannual HIV/AIDS Sustainability Index and Dashboard, or the SID. So here is a little bit of data from the SID. So the SID was completed every 2 years by PEPFAR teams and in-country stakeholders beginning in 2015. It was designed to sharpen the understanding of each country's sustainability landscape in order to assist PEPFAR and countries in making informed HIV/AIDS investment decisions. So the data here on this chart represents the aggregate SID scores for 29 countries over 3 reporting periods. And you can see that despite more than 7 years of significant investment in sustainability-focused activities, only incremental shifts in the SID scores were observed. And you'll note that there is nothing post-2020 because COVID has influenced a lot of our structures. And so I left I used 2019 as the cutoff point for all of my data because I did not want to include the effects of COVID. So these minimal changes over time in the SID score suggest that PEPFAR countries really weren't making the level of progress towards sustainability that one would expect and what needed to be made to sustain gains made under PEPFAR, and not only sustain those gains, but then transform this massive program into a fully country-led response. So PEPFAR was designed to operate as a bilateral humanitarian aid program using a government-to-government approach. It was conceptualized as a better funded alternative to the multilateral UN Global Fund for HIV, tuberculosis, and malaria, which you're probably all aware of. So just quickly, I refer to this idea of multilateral multiple times. And so I just wanted to include the definitions here for those who may not be familiar. So bilateral refers to, it's a foreign aid model, and bilateral refers to government aid, or when one government directly transfers aid or funds or resources to a recipient country. And that would be a program like PEPFAR. And then multilateral is aid provided by many governments and routed to a single international organization. And that's organizations such as the World Health Organization or the Global Fund. So establishing, thinking there's a lot to unpack with the idea that PEPFAR was created as a bilateral program. I'll just give a little synopsis here, but I highly encourage everyone, even if you're not as interested in HIV, but you're interested in international health or global donor programs of any sort, I encourage you to read this Emily Bass book, To End a Plague: America's Fight to Defeat AIDS in Africa. It's a really interesting and thought-provoking book. So establishing PEPFAR as a bilateral program really allowed the US, one, to shape foreign policy from hard power as it had been coming out of the Cold War to more of a soft power approach, so leveraging diplomatic channels. It also enabled US government agencies administering PEPFAR to work directly with the central governments of recipient countries. So with a model like we have with the Global Fund, the United States is putting in significant resources, but we aren't then directly working with the recipient country governments. Establishing a bilateral program also enabled the US government to control target setting. It fostered shared fiscal and programmatic accountability between the US government and the recipient country's central governments. So that's a little bit about why PEPFAR was designed the way it was. And so then to take full advantage of the benefits of the bilateral donor approach, PEPFAR's administrative structure, comprising multiple federal agencies, which you can see, I don't have all of the agencies listed on here, but you can see some of them. PEPFAR's administrative structure, comprising all of these agencies, was centralized into this hierarchical model, this overly simplified hierarchical model that you see here on this slide. Now, it's important to note that at the time of PEPFAR's development, program architects were really in a race against activists, and you can read more about that in the Bass book, who preferred the multilateral global fund and alternative competing global AIDS response legislation being developed within the US. PEPFAR planning meetings, because of this, PEPFAR planning meetings were kept really small, and there was very little transparency around the entire process. Early planning efforts focused on securing congressional support and ensuring a 5-year budget. Unfortunately, so the literature doesn't contain any mention that the architects of PEPFAR gave any consideration to the wider or non-health sector specific host country governance structure, policies, or systems. So this is very unfortunate. But again, PEPFAR was established as an emergency humanitarian response. No one envisioned that this would be, we are currently celebrating our 20th year. So PEPFAR was not designed in this way. So the literature actually suggests that neglecting to design donor programs that align with existing economic and political structures can lead to negative unintended consequences. And here on this slide, you can see several of those unintended consequences of PEPFAR listed. These are taken from the literature. And my slides, I'm not sure if we'll circulate them, but there's the bibliography at the end of the slides. The unintended consequence of PEPFAR that really interested me was the last one at the bottom of the slide here. And it's the assertion that by law, that PEPFAR, through its centralized structure, negatively influenced national decentralization strategies. So, what is decentralization? Decentralization is considered both an ideological principle and a process, and there is no standard accepted definition really for either. So for this project, the following definition proposed by Rondinelli was used. Decentralization is a process by which administrative, fiscal, and decision-making activities and authorities are distributed or delegated away from a central government to subnational governments, including local governments, civil society, and the private sector. So decentralization has been promoted as a priority development strategy for over 40 years because it promotes democracy and moves decision-making and service delivery accountability closer to the beneficiaries. It's really important to note, though, that the country-level decentralization and sectoral decentralization, including health sector decentralization, can occur independently. So both are informed by constitutional laws and legislative policies. So in a country, you can have country-level decentralization strategies, activities, legislation, and those can then influence sectoral level decentralization. So thinking about the health sector. So they're not always an exact mirror of each other. I didn't find anything in the literature to suggest that PEPFAR works to align itself with either the national or health sector specific decentralization strategies. Although anecdotally, I do know that there's been an effort in some countries, particularly Kenya, to begin shifting funding to subnational units. And I was actually on a call with some colleagues in the Philippines office, and they were also talking about some decentralization initiatives happening there. So things are moving more in that direction. So I think it is fortuitous timing that I have these findings. The literature does suggest a complex relationship between decentralization and health outcomes, with quantitative studies more likely to find a positive relationship between population level than individual level outcomes. And you can see here the finding in red down there at the bottom, highlighted on this slide, suggests that when funding functions remain centralized within a health system, as they are with PEPFAR, for example, this can offset the intended positive effects of decentralization at lower levels. Although there is literature looking at the relationship between health sector decentralization efforts in LMIC and HIV-related health system outcomes, many in PEPFAR countries, I was unable to find anything looking at the relationship between country level decentralization, so again, not sectoral, country level, and the overall country's decentralization strategy, and the HIV treatment cascade. And so if you remember, that's the 95-95-95 that I presented on earlier. A project in Brazil did find that funding a national HIV response solely from the national level could lead to a centralizing effect within the health system, working counter to national level decentralization efforts. So reading about this project really led me to question the relationship between PEPFAR, which has a centralized design and represents a highly significant proportion of HIV funding in many LMIC, and then national level decentralization efforts. Again, another busy slide, which is a running theme in this presentation. So this conceptual framework highlighted on this slide shows the mechanisms through which PEPFAR could potentially be influencing decentralization strategies, and in turn, HIV outcomes in the countries in which it operates. However, before exploring even how PEPFAR might be influencing national level decentralization strategies and efforts, it's important really to first establish if there is any relationship between, or any signal of a relationship between national level decentralization and HIV outcomes, which is where my study came in. So an improved understanding of the relationship between decentralization, PEPFAR, and HIV outcomes could potentially yield previously unexplored policy and programmatic opportunities that could facilitate the achievement of the 95-95-95 goals, and therefore strengthen in-country sustainability efforts, which in turn will actually protect US investments made through PEPFAR. All right, so let's move into the methods here. The aims of this study were to establish the nature of the relationship between fiscal decentralization and the HIV treatment cascade and LMIC, determine if PEPFAR moderates that relationship, and then explore the effects of administrative and political decentralization on the treatment cascade and compare these effects to those of fiscal decentralization. The purpose of the project was to determine if there is a relationship between fiscal decentralization and the outcomes that comprise the treatment cascade, the HIV treatment cascade in low and middle income countries. Now, rooted in the counter-normative hypothesis that there is a negative relationship between fiscal decentralization and the HIV treatment cascade outcomes in LMIC, this study employed a cross-national ecological design to answer 3 research questions, and you can see them highlighted in the yellow box. 1, are LMICs that have PEPFAR programs actually better at controlling their HIV epidemics than LMIC that do not? Do LMIC that have higher degrees of fiscal decentralization have better HIV treatment outcomes than less decentralized LMIC? And then does the presence of PEPFAR change the relationship between fiscal decentralization and the HIV treatment outcomes? Now, I could talk a lot about these methods. I'm going to give a little bit of overview, and if you have questions and we don't have time for any method questions, you can connect with me after and I can share my dissertation, or we can talk through these methods in more detail. But the 4 primary dependent variables in this study were reduction in HIV incidence per 1,000 population of all ages between 2010 and 2019. And again, this is not one of the treatment cascade variables, but it was the variable used to explore the effectiveness of PEPFAR. The second primary dependent variable was the percentage of people living with HIV who know their status. 3, the percentage of people living with HIV receiving ART, and 4, the percentage of people living with HIV who have suppressed viral loads. Data for the independent variables was obtained from the 2019 UNAIDS info data set, and I already discussed that 2019 was selected as the upper date to avoid possible COVID effects. The first dependent variable, reduction in incidence, was calculated and used to answer research question number 1. For the calculated reduction in incidence variable, 2010 was selected as the baseline year because it represented the period when the most incidence data was available across all LMIC in the UNAIDS data set. The last three dependent variables represent the the testing and treatment cascade, or the 95-95-95. These outcomes were used to address research questions 2 and 3. To mirror methods from similar quantitative studies looking at the relationship between health sector decentralization and health outcomes, this project sought to use time series data. The data selected for the time series were based on the availability of data in the UNAIDS 2019 data set. So for example, UNAIDS data set had ART data for the largest number of countries for the consecutive years 2010 to 2015, while it contained the largest consecutive data set for HIV status for 2015 to 2019. All right, now into the primary independent variable of interest, which was fiscal decentralization as defined by Ivanina and Shaw, the decentralization index. So the Ivanina and Shaw, and so I will point you to the box on the left-hand side. The Ivanina and Shaw decentralization index, which covers 182 countries and represents only one point in time, 2005, was the only decentralization index available that included all PEPFAR supported countries. Now you may be wondering why fiscal decentralization. Well, fiscal decentralization was selected as the independent variable of interest because the majority of empirical literature focused on decentralization and health outcomes looked at the relationship with fiscal decentralization. Thus, the strongest evidence existed linking fiscal and health outcomes. Political and administrative decentralization were included as secondary independent variables. And you can see the box on the left of the slide provides the Ivanina and Shaw definitions for each type of decentralization and then lists the measures comprising each indices. Fiscal decentralization, the primary variable of interest, is highlighted in yellow. Again, my dissertation has a lot more detail on these specific measures that were included in the Ivanina and Shaw index. Additionally, in my literature review, I did explore 3 different ways the 3 primary ways across the literature that decentralization is measured, and I decided to go with an index. So, all right, let's move to this slide. So status as a PEPFAR supported country was also included in the models as a binary variable. PEPFAR provided varying degrees of monetary and technical support to over 45 countries in 2019. The 25 countries selected for this analysis were those for which a PEPFAR country operating plan, or you might hear it called a COP, for 2019 was available on the PEPFAR website. These 25 countries represent the largest PEPFAR programs. And you can also see on this slide, again, that for the 25 countries included, PEPFAR's proportion of the national HIV budgets ranged from 30% to 98%. 172 countries for which UNAIDS had any data in 2019 were selected for potential inclusion in the data set. A series of data exclusion criteria were then applied to the data set. After the application of exclusion criteria, the final data set comprised 96 countries. Using the final data set of 96 countries, 4 analytic data sets were created, 1 for each dependent variable. 8 countries included in the final data set had data in the UNAIDS 2019 data set, but it was not the data for the 4 dependent variables of interest. Therefore, those 8 countries, were also left out of the final analytic data sets. A list of the countries included in each data set could be found in the appendix of my dissertation. Again, I'm not going to go through each one of those. The models were built using a stepwise approach, and all analyses were conducted in R. The first step was to use descriptive statistics to generate histograms and scatter plots depicting the distribution of countries. The second step was to conduct the univariate analysis. During this step, each dependent variable was included as tertiles, quartiles, and quintiles in each of the univariate models for each independent variable. The middle group was selected as the referent group. The final grouping selected for inclusion in the multivariate model was based on which was most appropriate for each model. I'm not going to give you all the details here. So finally, the last step, the multiple linear regression models with control variables were built. PEPFAR was added as an interaction to the model to determine whether this intervention affected the relationship between decentralization and the outcomes of interest. Next, additional measures of political and administrative decentralization were fit to explore the effects of those other two types of decentralization on the outcomes so that I could compare those to the effects between fiscal decentralization and the outcomes. Each of the 4 multivariate models are highlighted in yellow on the right side. Each box lists the type of linear regression that was used for the final analysis, as well as the number of countries and observations included. 3 models were built for each of the dependent variables for a total of 12 models. This is a cross-national study. We can see that those are relatively small data sets. And so we all should know that cross-national ecological studies are known to have multiple limitations. These limitations are described on this slide, as well as limitations of the decentralization index and low sample size. These all need to be considered when interpreting the results of this study. And I just wanted to, I think it's really important to highlight that quantitative analysis cannot depict the dynamic sociocultural, historical, economic, and development context of LMICs. They are very unique and play a very important role in where each of these countries is in the rollout of their national HIV program. This is really important to think about, especially with this study, given that the quantitative analysis is not being combined with a comparative analysis. So all that said, while the results from this study are the first that I have seen exploring multiple types of decentralization on the HIV treatment cascade outcomes, the results may not be generalizable, and they're really intended to be a starting point for future empirical policy and programmatic exploration. All right, so into the results. Some of these are dense. So I'm not going to discuss the descriptive data. If you're interested in that, again, follow up with me. I can share more on that. I do want to just, though, highlight one thing from the descriptive data that we will see repeated again in the adjusted, that we see in the unadjusted data that will be repeated in the model data. So when looking at these charts, PEPFAR supported countries are represented by the black bars, and non-PEPFAR supported countries are represented by the gray bars. The figure on the left of the slide highlights the mean of the dependent variables by fiscal decentralization tertile and PEPFAR status across LMICs after the application of data exclusions. The figure on the right highlights the same, but for political decentralization tertile. And as you can see, PEPFAR countries experience greater positive changes across dependent variables than non-PEPFAR countries. And in both figures, looking at panel A, PEPFAR countries experience greater reductions in HIV incidence between 2010 and 2019. And you can see that the most fiscally decentralized countries, or those in tertile 3, experience the greatest reductions in HIV incidence, while the least politically decentralized countries experience the greatest reductions in incidence. So this inverse relationship is highlighted by the red arrows. And this is really the interesting pattern that we are going to see again in the adjusted models. We're going to move into the regression results. I'm only going to be discussing models for which there was a significant result. Interestingly, administrative decentralization was not statistically significant in any of the models. And so that is not included. Political decentralization was significant in the models for reduction in incidence and percentage of people on ART. So I will talk us through those. So moving into the regression estimates, I just want to do a time check here. Let's see. Okay, over. Okay. The table on the left shows the regression estimates for the fiscal decentralization model for reduction in HIV incidence between 2010 and 2019. After accounting for Gini, which was the only statistically significant confounder in the univariate model, the multivariate ordinary least squares regression model suggests that LMICs with PEPFAR programs experience a significantly higher reduction in HIV incidence per 1,000 than LMIC without PEPFAR. This finding will be repeated across outcomes. And I'm going to move us forward. We could spend a little bit more time on this, but I'm going to move us forward into the models that will answer questions 2 and 3, just so that we can cover everything here. Sorry, wait a minute. Fiscal decentralization, reduction in incidence. So political decentralization and reduction in incidence. I'm going to skip forward, but I'm just going to highlight here this slide. This slide here just shows you a little bit of a closer look at the relationship between the reduction in incidence and fiscal and political decentralization. And so here the unadjusted and adjusted data suggest that countries that are more fiscally decentralized have experienced greater reductions in incidence than less decentralized countries. Unfortunately, you can see some of my important questions that arose from this slide listed on here. We don't really have time to unpack that. And so we're going to move forward, at least to see if these patterns repeat themselves with the treatment cascade variables. So moving into the regression estimates for cascade variables, or the primary dependent variables of interest, starting with percentage of people of all ages who know their status. We can see from this table highlighted in red that LMIC with PEPFAR programs have a significantly higher percentage of people who know their HIV status than LMIC without PEPFAR. Interestingly, LMIC with mid-levels of fiscal decentralization, or those in tertile 2, were significantly more likely to have higher percentage of people who know their HIV status than LMIC in the lowest tertile, or tertile 1. You can see that here with the red arrow. PEPFAR was not observed to have a significant interaction effect in this model, and neither administrative nor political decentralization were statistically significant for the percentage of people who know their status. Moving on to the next primary dependent variable of interest, percentage of people of all ages living with HIV on ART. Again, we can see in red text that LMIC with PEPFAR had significantly higher percentage of people living with HIV on ART when compared to LMIC. So for this, without PEPFAR, apologies. For this variable, we can see that when compared to the least decentralized tertile, LMIC in tertiles 2 and 3, or increasingly decentralized LMICs, have significantly higher percentage of people of all ages living with HIV on ART. PEPFAR was not observed to have a significant interaction effect in this model. I'm gonna just, in the interest of time, I'll just highlight here that the only PEPFAR interaction effect between decentralization and HIV treatment and an HIV treatment cascade variable was observed between political decentralization and percentage of people of all ages living with HIV on ART, with the most politically decentralized PEPFAR LMIC, or those in tertile 3, having a significantly lower percentage of people of all ages living with HIV on ART. The red arrows on the figure on the right highlight another interesting pattern. You can see that as non-PEPFAR countries become more politically decentralized, they tend to have more people on ART. While for PEPFAR countries, it appears that countries that are less politically decentralized have more people on ART. When comparing the directionality of the relationship between fiscal and political decentralization and percentage of people on ART and PEPFAR LMIC, we observe a trend like that observed when looking at the relationship between reduction and incidence. So based on this data for PEPFAR countries, it appears that those that are more fiscally decentralized and less politically decentralized are better at getting people on ART. So quickly moving to the model for the final cascade variable, which is percentage of people with HIV who have suppressed viral loads. As with the other dependent variables, of course, we see that PEPFAR countries are performing better. However, we also note that fiscal decentralization was not significant in this model for percentage of people with suppressed viral loads. And we'll talk a little bit about that in the next section. So conclusions and recommendations, synopsis. All right, question 1 of my dissertation. Are LMIC with PEPFAR programs better at controlling their HIV epidemics than LMICs without? Yes. PEPFAR countries experienced significantly larger reductions in HIV incidence than LMIC that did not have PEPFAR, and PEPFAR countries demonstrated significant reductions across the treatment cascade when compared to non-PEPFAR countries. So the results of this study clearly establish that LMIC with PEPFAR programs are better at controlling their epidemics. Now, moving to question 2. Do LMIC that have higher degrees of fiscal decentralization have better HIV treatment outcomes than less decentralized LMIC? LMIC, so the answer is yes, but. Okay, so LMIC that are more fiscally decentralized do have better HIV treatment outcomes than LMIC that are less fiscally decentralized. PEPFAR supported LMIC that are more fiscally decentralized have significantly better HIV outcomes, both reduction in HIV incidence and treatment cascade outcomes than their non-PEPFAR supported counterparts. No statistically significant findings were related to the relationship between fiscal decentralization and viral load suppression, but I suspect that this, given the positive results we saw with the other treatment cascade variables, I suspect that rather than there being no statistically significant relationship here, there was just, in fact, a limited amount of data. This was the smallest of the data sets that I had. Question 3, does the presence of PEPFAR affect the relationship between fiscal decentralization and HIV treatment outcomes in LMIC? So my answer is maybe. More research is definitely needed. The presence of PEPFAR did not appear to affect the relationship between fiscal decentralization and the treatment outcomes. However, PEPFAR did appear to affect the relationship between fiscal decentralization and HIV incidence, and political decentralization and people with HIV receiving ART. So given these findings, it really isn't possible to rule out the idea that PEPFAR affects the relationship between fiscal decentralization and HIV treatment outcomes. It just may be that the methods used for this study were insufficient to identify an effect. So conclusions. Based on the findings of this research, I've concluded that PEPFAR has been successful at decreasing new HIV infections and delivering services in LMIC, particularly in countries with higher degrees of fiscal decentralization and lower degrees of political decentralization. The role that PEPFAR plays in the relationship between decentralization and HIV outcomes in LMIC is complex and unclear, but warrants more study. And reducing HIV incidence and the HIV treatment cascade are not interchangeable measures. This should be considered both when developing measures of HIV program sustainability and when moving forward a research agenda focused on decentralization. I'm not really going to talk about this because I want to have a few minutes for questions. I do just want to highlight this unexpected finding of this inverse relationship between fiscal decentralization and political decentralization for reduction in incidence and percentage of people on PART. I was not expecting that, I guess, and also the absence of any signal related to administrative decentralization. I found that also very interesting. So I had a few recommendations for PEPFAR. I kept these very high level. PEPFAR should, build an understanding of the current health sector decentralization policies and the national decentralization strategies in the countries in which it operates. They should leverage existing research and support additional inquiries to build on the findings of this study. And then PEPFAR should seek to align their policies with national and health sector specific decentralization policies. All right, so that brings us to the questions and answers. And I guess we can do questions. We probably won't have time. I have a discussion slide on here, but maybe we won't have time for that. So I will just turn on my camera and open the floor to questions. I was not following in the chat, so if there's anything in the chat, maybe someone can just raise that to me.
Yeah, let's go ahead with the questions. I haven't seen any in the chat myself, so anyone.
And if you don't have a question, then feel free to think about the discussion questions that I had posed on my slide, but I've taken down now. What do you think the implications are of the study for PEPFAR? And then how do you think PEPFAR could use this information to support the transition of programs to the host country governments? So questions or reflections on any of those thought topics.
So while we wait for other people to jump in with questions, Toby, thanks very much for this excellent presentation. Of course, very, very informative from a policy standpoint, but also from a general HIV progress and programming standpoint. I wanted you to just maybe shed some more light around the SEEDS, the Sustainable Index score that you talked about. How was that related, or was there any relationship between the score that you saw, because you kind of saw results that didn't seem to align with what you would have expected in terms of progress, but was that impacted by the level of funding? So was there a difference in terms of the SEEDS that you saw in relationship to, the different percentages of funding?
Yes. So I think, and I'm trying, as you're talking, I'm trying to pull this screen. I wanted to just share the screen just so everyone can see kind of what we're talking about. Are you seeing that slide, Juliet, that you were referring to?
Not yet.
Okay. Oh, maybe I didn't click the final share. Sorry. Yeah. Okay. Sorry. Here we go. All right. So you should be seeing that now. Yes. I'll just say, so Juliet had raised not the same point, but a similar point about the relationship between the proportion of funding and the HIV outcomes when I was presenting my dissertation. And so for my work, at least, I went back and I put, I created a variable, yes, sorry, I created a variable to represent proportion of funding, and then the funding was not significant when included in the univariate models, and so therefore was not included as a potential confounder in the multivariate models. But so that's for the work I did. But thinking about the SIDS, there may be some analysis. There have been more analyses of the SIDS data done through the PEPFAR agencies. I don't know it well enough to speak to how the scores aligned with the funding. I think that if I were going to hazard a guess, much like in my own work, that I found that the proportion of funding was not significant, I would say that I don't think that I don't think across all of the countries that we would see that there was a significant difference between SID scores in countries based on the level of fundings. I think the SID scores, knowing what all of those indicators were, I would hazard that the differences would be more related to some of those sociocultural, economic, and political factors that, of course, I could not capture in my study, and that PEPFAR had not done a deep dive in with their SID data. So if that answers your question in some way.
That makes sense, because I was wondering whether you would take this and say, look, we need to inject more funds because we haven't yet reached that sustainable level that we're expecting. And so again, just thinking about what's next for PEPFAR, given that now they're discussing whether they should extend it or stop it or, alter it.
I would say there are greater minds, like better minds than mine, working on strategic funding,
right.
And thinking about those very nuanced approaches to targeting the resources. Yes, that's what I would say.
Great. Any other comments, questions? Please go ahead and either just open your mic and ask, or any clarification.
I know that this could not have been clear to everyone because I've been working on it for years, and even I don't find it that clear when I say it out loud. So please ask your questions.
Maybe I'll ask a question about it seems like you're looking at impact of the PEPFAR program, and there was a substantial proportion of LMICs that received the program, and maybe at different points in time. But looking at your control variables that you mentioned, I was wondering if and it seems like you yourself were saying this is really hard to estimate this effect. But do you feel that with the information you've been able to incorporate the conditional on those covariates, that this program was essentially randomly distributed, or is there really a lot more to how the countries were selected for PEPFAR in terms of how they were, the selection process?
I would not in any way suggest that the countries are randomly selected. Like I said, initially PEPFAR was kicked off in the 15 countries with the highest burden. They also happen to be, I think, the fall within the lower third of the low and middle income countries. And then the way that PEPFAR then has scaled up has been very selective. And so again, based on different political, economic, and kind of diplomatic opportunities that have presented itself. So I would not say that this is a general or a random sample at all. Mm-hmm. And I think I would say, and this is just to touch back on methods, I think that if I were reflecting on this work I did, and I was not a full-time mom and a full-time employee at CDC, and I was doing this as my full-time job, I think I would have probably developed my own decentralization measures. And rather than use an index, but I think that would be very complex, and it would be very time consuming, and really just didn't lend itself to the project that I decided to take on. But I think there's a lot of work to be done, a lot of interesting work around the relationship between decentralization and health systems. And so I would love it if some of my colleagues could take that on, or if PEPFAR or WHO or UNAIDS or any of my other multilateral colleagues could explore this idea a little bit more and look at more appropriate measures of decentralization for low and middle income countries.
Very nice. Any other comments, questions? Still have a minute or so.
I see we have a hand, Christopher.
Yeah, Toby, thank you for that nice talk. It seems to me that the countries that received PEPFAR were very, very different, and it's almost hard to do the combination analysis that you did. I know I probably did one of the first studies on decentralization in 1990 with a colleague, Charles Rabukwali in Uganda. And what we found was that aid, and this long before PEPFAR, but there were the aid that was given to Uganda at the time in the form of money and in the form of expertise, access to testing, and so on and so forth. There were three tiers. There was the tier of the ministry, there were the middlemen, and then there were the clinics, the front lines. And everything got gobbled up in the first two tiers, and nothing got to the front lines. So fast forward, when the PEPFAR was rolled out, I worked with Peter Mugenier, who was probably the most influential person in convincing Bush to make this, $19 billion commitment to PEPFAR at the time. And it was interesting what happened in Uganda as the money started to come. It was not distributed in a way that made a lot of sense. For example, groups that had pre-existing clinics set up with thousands of HIV patients didn't get any money to help support the care of those patients. Whereas other groups that had very little infrastructure in place got all the money, or seemed to get all the money. And so it, and I know anecdotally, every country kind of had a different pattern of rolling things out. So I just wonder what you thought about aggregating things together as opposed to taking a country by country basis.
So yeah, that's a really great point. And as you're talking, I'm reflecting. So I had a number of meetings with my chair and then the committee, and as we were talking, when I was thinking about this idea, I realized I approached this really as like a program manager, like a hardcore PEPFAR staff person. Like that's my job. That's what I do. I'm thinking we're transitioning to sustainability. I'm reading the literature. I'm seeing that there are these unintended consequences. And I know that internally we are managing the program, and I'm overstating things, right? But internally in general, we are managing the program in a way that really focuses on kind of the same things we focused on for 20 years. So the health system, like we're moving towards strategic financing, but we're not really talking about anything different. And so when I approached this project, I did not approach it as much from an academic perspective as I did an interesting kind of thought-provoking policy related question in terms of as PEPFAR management. So I wanted the findings from this to be able to spark conversation in PEPFAR, and the idea that we definitely need to be thinking a little bit more broadly when we're thinking about sustainability. And so for that reason, I agree. I wholeheartedly agree with you that a country by country deep dive into the very specific landscape of each PEPFAR country would be probably the best next step. And my objective with this work was just to start sparking conversation to say, maybe it is worth putting a little bit of effort and resources into more exploration of decentralization and the relationship with PEPFAR. And so that's really what I would say. This is a jumping off point to get people's attention.
Any other? I think we are right on time, on top of our hour. So thank you so much for this very interesting talk again, Dr. Supiano. And with that being said, I would like to thank everyone for attending and signing on, and we will sign off now.
Great. And I'm putting my email in the chat in case anybody, my personal email, because I know that my UGA one will end at some point, but there's my email in the chat. If anyone has thoughts or questions or wants to see the dissertation, I'm happy to continue talking about this. So thank you. And thank you for inviting me. And please spend some time thinking about World AIDS Day tomorrow and your role in ending the epidemic.
Thank you so much.
Thank you.
Thanks, everyone. See you next semester.